As we now know, Senator Kennedy survived about 15 months with this particular type of brain tumor. And I had a chance to sit down with a specialist at the center where Kennedy was treated to try and find out why these tumors are so deadly and what possible treatments lie in the future. Henry Friedman is a neuro-oncologist at the Robert Tisch Brain Tumor Center at Duke University. What makes this tumor so problematic? And what I mean by that is, for the layperson, I mean, what makes it problematic and what causes death in a patient that has this?
The problem with a glioblastoma multiforme is at the time it's diagnosed, it's all over the brain. You may see a tumor that on an MRI or a CT scan breaks the blood-brain barrier, and you can see the so-called contrast getting into the white ball there. But there's microscopic disease everywhere else, all over the brain. So you have to do both local therapy to try to treat the tumor where you can see it, but you've also got to do therapy to treat the disease where you can't see it, the microscopic disease. Well, if it's your finger, I mean, you can go around being known as Four-Fingered Henry if you sacrifice that pinky, which has a cancer. But in the brain, it's a much more difficult proposition.
When you look at glioblastoma overall, people hear that an operation may be useful, chemotherapy, radiation, but they hear at Duke there's a lot more weapons in the armamentarium here. What are some of those weapons? How do they come to be?
There are definitely more weapons than just surgery, radiation, and the standard chemotherapy would be a drug called temozolomide, since probably the late 90s, 1999. But there's progress being made with the ability to deliver radiotherapeutic isotopes directly into a tumor crater through monoclonal antibody therapy. A company has licensed that approach. There are vaccines that appear to allow one's own body to stimulate an immune response against the tumor. Companies have licensed that approach. There is an anti-angiogenesis drug called Avastin, which appears to have a profound effect on recurrent glioblastoma and will soon be getting its try in a very large national and overseas trial for patients with newly diagnosed disease. And then more than that, in the last number of months, both Science and Nature had papers that looked at 620,000 genes, respectively, in glioblastoma, finding patterns of abnormal genes that are either turned on or turned off or missing that give us clues to really find ways to more precisely target a tumor. And what's going to come in the future, and it's going to take some time, if someone has a brain tumor, their tumor is going to be analyzed and then use drugs to target those pathways. And my personal belief is that targeted individualized therapy is the wave of the future. And the progress we've made so far is going to be dwarfed by the ability to do that.
Would you describe neuro-oncology the same way it was described to you when you decided to go into this field?
I think in the last 5 years there's been some substantial advances, small steps, not giant steps, but there are things that are changing in the field where I can confidently say that there is a fraction of patients, an increasing fraction, but a minority, but still increasing fraction of patients with the worst of the worst, which is the grade 4 malignant gliomas or glioblastoma multiforme, who are being cured of their disease. Most physicians out there would say that that is simply nonsense, that there is no cure for those patients. But we have patients around 5, 6, 7, 8, 10, 12 years without recurrent disease. I think we've made our point.
If someone is diagnosed with this type of tumor, a grade 4 glioma, what would most doctors tell the patient?
Put their affairs in order. You've got 6 to 9 months, maybe a year to live. Live a good life, but put your affairs in order. They would be told that they're incurable and to move on with their life as best they can for whatever small amount of time is left behind.
But what made you sort of think differently than what a lot of doctors think in this country?
We're told that many of the things that we do are pushing too hard and just let the patient have what their remaining time is going to be and die with dignity. Well, I don't want my patients to die with dignity. I want them to live with dignity. And I think we can give them therapeutic strategies which minimize an adverse effect on their quality of life and give them a chance to survive.